يعني قصدي دي مش متشافه اللي ورا دي، الشاشه دي مش متشافه.
انت رايك
الكرسي ده
يعني وانا كده قمت اتحركت وانا قاعد مرتاح، انا قاعد مش احسن لي.
يودي برا بس الكرسي اكثر منه.
أبدأ. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين. Today our lecture title is Regional Anesthesia. My name is Hassan Muhammad Ali. I'm an anesthesia consultant in Meeqat Hospital, Associate Professor of Anesthesia and Pain Management in Cairo University, Faculty of Medicine. Today our goal in this lecture is to know the types of anesthesia, definition of both general and local anesthesia, and to clear some doubts about regional anesthesia, and lastly to know the pros and the cons of regional anesthesia. Here is our anesthesia recipe. It's easy, simple and delicious. Come and share us. Okay. Meaning of food anesthesia. What is the meaning of food anesthesia? An means no, and anesthesia means sensation. So sensation had a wide spectrum. It is not only about the pain, but also about the touch or tactile sensation, as we can feel a cotton moving over our skin. Also temperature, that we can differentiate between hot and cold. Position, so we can know we are sitting or standing, our finger is like this or like this. Vibration, so we can feel a mosquito or a insect moving over our skins. And lastly, pain. Pain is our concern. We need to abolish pain. So the aim of general anesthesia or whatever the type of anesthesia or local anesthesia is to abolish pain. This is our target. So we have at the end two types of anesthesia, general, regional. Even we can combine both. We can have general and local anesthesia in the same patient. So what is the definition of general anesthesia? We have a lot of definitions, which is very scientific, and here I have chosen a very simple one. It is a drug-induced loss of consciousness during which an individual is not arousable even by painful stimulation. If you can here notice, in general anesthesia we are concerned about consciousness, not about pain, about consciousness. So JA, or general anesthesia, the first issue, the first pillar in general anesthesia is to lose conscious, plus or minus loss of pain sensation. On the other hand, regional anesthesia makes a specific part of the body numb with no feeling to relieve pain or allow surgical procedure to be done. In another word, loss of pain sensation in a territory. If you can notice in this definition that the regional anesthesia is concerned with pain, not with consciousness, which is our goal from the start. We have a lot of types of regional anesthesia. The most common in the spinal and the epidural, and something also called nerve blocks. So if we use nerve blocks, we can block a region by itself, a hand, an arm, a leg, a foot, a finger, even a small patch of skin in your body. So in regional anesthesia, you didn't mention a consciousness. So the patient can ask himself, I will be awake? Yes, you will be awake, but you will lose the feeling while you are conscious. And amazingly, you can lose conscious while you are still feeling, as we have mentioned in general anesthesia. Some types of patient, while if we give him general anesthesia, he can give us a response on the level of sympathetic system, like hypertension or tachycardia, which reflects a pain, or even he can move his hands. If you have a patient in the ICU, for instance, in a deep coma, and you have tried to make suctioning, the patient can reflex by making a grimace like this by his face, or even he can pull your hand out. So to lose consciousness doesn't mean by itself that you are not feeling. You can still feel. So remember, 3 very important issues. You can feel no pain while you are awake, like here in our issue regional anesthesia. Moreover, you can feel pain while you are not awake, like deep sleep or deep coma. And amazingly, even you can feel pain, but it is not annoying, like a frontal lobectomy. How this can come is a big issue, but if we cut the frontal lobe, the patient can still feel pain. I am feeling pain, but it doesn't annoy me. So the pain has 2 components, to feel pain and to annoy, to have annoying from the pain. Then you can ask a question. If I am conscious, I can see the surgeon cutting my body. Don't worry, I will show you a picture here. Here is the patient. You can see this is a patient lying flat, and here is a screen, and the head of the patient is behind the screen with the surgeon, with the anesthetist, and the surgeon will do the procedure here. So you will not see the surgery. Even if you have regional anesthesia and you are fully conscious, you will not see the patient, the surgeon cutting your body. So what is the benefits of regional anesthesia? After that, tell me why to choose regional anesthesia. Primarily, you will not have a complication that happened usually with regional anesthesia, like drowsiness, nausea, vomiting, and dizziness. And if the regional anesthesia will stand or lasting after the surgery, you will have no pain. So you can move and ambulate early, and so subsequently you can go home early and to return to your normal life as soon as. Some privileges or advantages like less incidence of DVT and less bleeding and a healthy baby. This is very specific to spinal anesthesia with cesarean section and with pregnant lady, and so spinal anesthesia is very important and truly indicated to the pregnant lady. What is the advantage of regional anesthesia? Before talking about this advantage of regional anesthesia, I need to emphasize on 2 points. It is not related to bowel problems after surgery, like constipation, pain and straining, and early drinking and feeding. Some patients think that if he cannot eat early, if he has a problem with bowel motions, it is related to the anesthesia. Actually, it is mainly related to the surgical procedure itself. Moreover, it is not related to the back pain. Some patients, while they will have spinal anesthesia, they are concerned that I will have back pain after the surgery of the spinal anesthesia. It can give an alert to a pre-existing pain, but it itself will not cause back pain. Only the needle trauma can cause back pain, needle like any needle in our body, which will disappear after 21 days. So what are the disadvantages of regional anesthesia? We have most common, which is post-dural puncture headache, and most dangerous, which is toxicity. The last one, toxicity here. This is the most dangerous, and this is the most common. And I will talk about both of them later on in details. We have allergy, very rare, hematoma, infection, nerve or organ injury, and you can see it's 1 in 100,000, 1 in 10,000, which is very, very, very rare, not to be concerned. But remember posterior puncture headache, which is very common, and toxicity, which is very rare, but dangerous, okay? Now I will talk about posterior puncture headache. This headache is very common with a wide spectrum of incidence from 0.001 to 30%. It is a headache that happened one day, 27 or 72 hours after the procedure, the spinal procedure, mainly with the spinal and epidural. It is a frontal or occipital headache that is related to the position. If the patient is standing, he will feel headache. If he is lying flat, he will not feel headache. And we can diagnose it by exclusion. It is very related to the patient type, like if you have a young patient, athlete, and pregnant patient. And it depends on the needle size and type. Unfortunately, it is unavoidable. If it will happen, it will happen. So how to manage posterior puncture headache? First of all, reassure your patient it is self-limiting and it will disappear in 90% of cases spontaneously. And if it is annoying the patient, ask him to have a bed rest, to lie flat, and to take a lot of fluids, and to have paracetamol, simple analgesia with caffeine. Caffeine is very, very important. It can relieve posterior puncture dramatically. And here is a proverb in Arabic we mention to the patient نام على السرير واشرب ميه وقهوه كتير, which can يعني تختصر, which can simplify these all 4 points in one proverb. Now we will start to give a patient regional anesthesia. This is a major procedure, not a simple procedure, and so you should prepare the patient in a well-prepared area. And before the region, you should discuss with the patient thoroughly what will happen, and to assure him and to have a consent, either verbal or written consent, and to clear all the doubts about regional anesthesia. Then crush, trolley, and equipment should be available, even if it's a very simple procedure. Prepare all your crush, trolley, and safety equipment. Put full monitoring. Put oxygen to prepare for any disaster. Sterilization is very important. Intralabel is a drug that will reverse the effect of local anesthesia on cardiac muscles in case of toxicity. At least you should know its location in your hospital and that it is existing. So in case of emergency, you can use it. Decision. When to take decision, either local or general anesthesia. First of all, you should discuss with your patient if he agree or not after clearing all doubts and explaining what will happen, if he agree or not. If he refuses, it's an absolute contraindication. Even if it is very beneficial for him, his rejection is an absolute contraindication. Local sepsis is an absolute contraindication. If we have a sepsis, abscess or pus in the place that we put our needle, it's an absolute contraindication. If we have a history of allergy, he told you that before I have spinal anesthesia or I have vision anesthesia and I experienced a toxicity or I experienced an allergy from these drugs, so it's better to avoid. And patient type itself, like young anxious patient or patient with psychological problem, is in anxiety or in depression or in agitation, and the acute kidney injury patients that are more liable to toxicity. Surgeon and the procedure, some surgeons are slow in their actions, okay, and they will take a long time, or even they are very apprehensive in the surgery, and they can say bad words, so it's better to avoid regional with these surgeons, okay. Procedure, if it's a very long, lengthy procedure, in a prone position, for instance, in a sitting position, so the patient will stay prone or lateral for a long time while he is awake. I will not prefer to stay 4 hours in a prone position. And lastly, anticoagulant. This is a very big issue, and it's not our time now or our place to discuss about anticoagulant, but it's a relative contraindication, very important to consider in your regional anesthesia. How to locate the nerve, how to locate your needle position. We have a lot of methods. Ultrasound, which is now the most updated thing, ultrasound. Now you can see your nerve itself, and you can see your needle moving to the nerve, and you can diagnose your complication on the spot. Keep the up-to-date method to locate your nerve now, even in spinal and epidural now. In the old days, we have nerve locator. This is a machine with a wire that will be connected to the needle, and it will elicit electrical impulse that will locate the nerve itself. It's in old days, now almost obsolete. The anatomical landmark and parathelia in the very old days, that you can draw a line over this bony landmark, over this tendon, and to put your needle over the nerve and to hit the nerve and ask you to feel parathelia. I am feeling parathelia. Now you are in the nerve itself. Very old days for us. It's no more now practiced. Lastly, X-ray and CT. Here we can locate the nerve itself by dye on the C-arm. But this is very concerned with chronic pain management, not with acute or with the surgeries in the chronic pain management. Pharmacology, what drug I will give? No need to go in the deep details, but at least you should know 4 items, very important items. Type of drugs, and every drug has its own pharmacodynamics and kinetics, and you can choose the best drug for your patient and use surgery. And then the dose, what is the dose that I will give? Never to exceed the toxic dose is very important. And the volume, that some blocks are volume dependent, like fascia iliaca and tab block. Even spinal itself is a volume dependent. If you give a very big volume, it will differ with the duration and with the level of the block. And lastly, the illusion. The illusion can determine which I will make analgesia or anesthesia. I will block the sensation and the pain or pain alone. And lastly, some drugs we give adjuvants that will prolong or to change the pharmacodynamics and kinetics of the drug, like dexamethasone and deprecidex. Now I will talk about an emergency, which is local anesthesia toxicity. This is very important to know and to diagnose. How I can experience toxicity? Easy if I exceed the toxic dose. If I give a direct intravascular injection, here in this point, even below the toxic dose, especially in vascular area like in the neck, even with 20 milligrams of local anesthesia, xylocaine, we can see convulsions and toxicity. So take care, intravascular injection, no need to exceed the toxic dose. Even with a minimal dose, especially in the neck and the head, you can experience toxicity. Rapid absorption area, like intercostal space, and here you can surprise that if you give small dose, it will increase the serum level rapidly and reaching the toxic dose before your expectations. Continuous infusion and the cumulative effect. Sometimes we put an epidural catheter or intrascalene catheter, subclavicular catheter, and to manage the pain management after the surgery, it will stay for 2 or 3 days. And so we can give a huge dose by continuous infusion. Sometimes it will exceed the toxic level, toxic serum level, and it will cause local anesthesia toxicity. So put in your consideration overdose, intravascular injection, rapid absorption sites like intercostal space, infusion, and I need to add here more the patient with acute kidney injury or impaired liver kidney function. How to diagnose is very important. The first signs in local anesthesia toxicity is tingling and numbness around the mouth. This sign is very query sign, and it needs an intelligent patient and intelligent doctor that he puts in his mind that I may experience local anesthesia. Usually, the patient and the doctor, both of them, will bypass this step. So, secondly, the patient will have a slurred speech and agitation. He will be agitated. And again, if you not put in your mind that the patient may experience local anesthesia toxicity, you may think that the local itself is not well functioning, so you will increase the dose, or you can think the patient is anxious, so you will give sedation. What type of sedation do you prefer? Usually midazolam, which is anticonvulsant. The third step is convulsion. So midazolam will bypass this step, convulsion. And then fourth step is coma. Midazolam can cause coma. And then cardiac and respiratory arrest. So if you have an agitated patient under local anesthesia and he is anxious and agitated, you can make he is now in a toxicity, and you will give him dormicum. So you will jump from this stage to this stage rapidly like this. Will calm down. You stop talking, and then he will be arrested. Okay. The first most important thing is to have your safety. Nah.
تتكلم هنا specifically to ماركين ولا ماركين عند زنكين؟
أي دراج. أنا قايل مش موضوع هنا الناس مش تخدير، فمش قايل بقى أي دراج يعني.
أنا بتكلم بالنسبة للماركين بيبقى عصر يعني لسه في أكتر كتير من
إحنا general يعني. These steps, general steps. We are now not taking specifically about each drug. Each drug has its own pharmacodynamics and kinetics. We are talking generally. So usually that will happen: tingling, agitation, convulsion, coma, respiratory, and cardiac arrhythmia. Some drugs make respiratory more than cardiac, and others make vice versa. It's not our issue now. But the patient will jump from agitation to coma if you give him dormicum. If you have no high index of suspicion, you may miss your patient. If you have no crash trolley and safety equipment and full monitoring and oxygenation, you can lose your patient. With a very simple procedure, slow anesthesia, and we will remove a simple ganglion like this, and at the end it will end by death. So take care, please. This is very, very important. Rare, but very, very important. So what to do? First, calm down, stop infusion, call for help, and make ABC, okay? And let the anesthetist manage. Here, this is an intravenous lipid emulsion, intralipid 20%, as we have mentioned before. This drug is specific to reverse the local anesthesia toxicity over the cardiac muscles. So in case of systole, this drug can reverse, we hope it can reverse the cardiac local toxicity on the cardiac muscles. Now we finished our lecture, conclusion and the home message. I think now we know about types of anesthesia. We have regional and general, and both of them combined. We know now about how to make the decision, which patient and which surgeon, and which type of drugs we can choose, the cost and the benefit of the choosing this type of anesthesia. And lastly, we have the pros and the cons, the advantages and disadvantages of regional anesthesia. Thank you. Any question? انت يا باشا بروف.
دكتور حسن كانت اللوكال انستيزيا اللي كانت موجوده